Hello and welcome to another podcast from Odell Technology. Today we're fortunate enough to be joined by Professor Dr Wright, the Director of Research and Innovation at Liverpool Heart and Chest. Hello, Professor Wright.
Hi, very nice to be here today.
Absolutely, and thank you for joining us. Professor, I was wondering if you wouldn't mind giving the audience your professional background and how it is that you ended up where you are.
I'd be delighted to. I'm a consultant cardiologist and have been in post for 20 years. I have a specialist interest in heart failure and heart rhythms and a subspecialist interest in implantable devices, pacemakers, cardiac resynchronization therapy devices, and implantable cardiac defibrillators. So I spend a lot of time looking at electrical traces, both from external monitors and from monitors within the heart. I've done a lot of research, particularly in innovation around development of technology for implantable devices, and that led to my appointment as honorary chair at Liverpool University and subsequently to the director post here at Liverpool Heart and Chest.
Okay, and tell me, I know that the Liverpool Heart and Chest is a significant player in the National Institute of Health Research. How do you fit into that project?
Well, we fit into that in a number of key areas. So the NIHR is basically the national funding source for research, and every hospital is allocated an amount dependent upon the number of patients they recruit, the number of studies they have ongoing, and the number of grants. And we've been fortunate enough to do rather well in terms of our patient recruitment, despite being an interventional tertiary cardiac centre. So we don't do a great deal of observational research. We often do what we call invasive interventional studies, and we've introduced a concept of comparative effectiveness where we try and recruit large numbers of sequential patients with no one being excluded from our research project, and hopefully that way it becomes a real world assessment of technology and intervention rather than a randomized control study in very false circumstances.
I'm very much aware that you've done many of the first-in-man studies for a lot of technologies, and I know that your facility has been involved in a lot of programs that have changed acute myocardial interventions and procurement and prescriptions in acute myocardial infarctions. Can you describe that work?
So that was the HEAT PPCI study, which was led by my colleague, Professor Rod Stables. This was a comparative effectiveness study in the context of acute myocardial infarction, where patients were randomized to either receive old-fashioned cheap heparin or more modern, expensive bivalirudin. And there'd been studies looking at both, but no real comparison outside those of randomized controlled trials. So this was 1,800 sequential acute myocardial infarction patients. Not one patient was missed or excluded. They were all randomized at the point of presentation and retrospectively consented the day after by patients, and we obtained special consent from the MHRA and IRAS in order to be able to do this. And this showed a very significant benefit for the more old-fashioned cheap treatment. So it was incorporated rapidly into the European guidelines, and we saw the use of bivalirudin in our centre and other centres across Europe reduce significantly, and the cost savings just within our centre was hundreds of thousands of pounds.
Okay, that's extremely interesting. I wasn't aware of that. Tell me, obviously research ensures the best standard of care, and that's something that you're able to do at Liverpool Heart and Chest. Is there any opportunity for patient feedback in the studies that you do?
We've been very keen to involve patients at every aspect of research. And in fact, the NIHR almost insists that patients are involved in the design of studies to make sure that they're patient friendly. We actually employ a patient ambassador here. So a patient is paid to act on behalf of all our research patients. He has specific input to the design of studies, and he takes feedback from patients, and he has a voice which is totally independent because he's paid through an external grant, and he feeds back at board level. And people actually take notice of what he says because he represents patients within our organisation. So he can be very influential in either the adoption of studies or the alteration of studies to make them more patient friendly. And he insists at every stage on patient feedback. So yeah, I think we've got that covered, but it's always an area that we strive to do better in.
Okay, I think that's a very important thing to note for a lot of our European audience. And also for the new MDR regulations that are coming into Europe and the new regulations coming into the United Kingdom very shortly. Tell me, I noted that you're the Director of Research and Innovation, which means you sit at the board. So you've got direct access to the executive management of the hospital, which obviously will help a great deal with accessing funding and changing pathways for patients.
Yeah, you'd be surprised just how difficult it is to access funding. And actually, although I have a seat at the executive board and the board of directors, the finance director within any NHS organisation is one of the key players, and the purse strings in our centre are held particularly tight. So I regularly do battle to try and increase the income that we spend, well, to increase the amount of money that the trust spend on research, but the trust are very keen that we demonstrate value for money as well as improved clinical outcomes in the research that we're conducting.
That's interesting. Speaking of clinical outcomes, are there any examples that you could provide for the audience about what you've done recently, perhaps in the community or in the hospital, that might relate to such an exercise?
Well, we've been very fortunate to be part of a nice AI technology evaluation. And for the whole of my time as a consultant cardiologist, and in fact, many years before in training, we used to monitor patients with symptoms of palpitations, dizziness, or syncope with external ECGs that they would wear for various periods, 24, 48, 72 hours, or even a week. And that technology hadn't changed for 25, 30 years, but now we have new wearable patches. And in fact, there's a plethora of them available on the market. So we particularly evaluated one, and we tried to do it in as a realistic way as we could, in terms of we'd been used to something for 30 years and then we introduced something new. So we did a direct comparison of what we had done with the new wearable Zio XT monitor patch produced by iRhythm. And we were supported by NICE, and there is an external evaluation by King's College London Kitech Company into the outcomes of our direct comparison. And we were so impressed, and our patient feedback was so fantastic, that we took that to the board and were able to put out a business case to switch from the old-fashioned wearable ECG monitors to a wearable patch. And we have pretty much moved wholesale, and we now purchase 2,000 units a year. And that was a robust independent process that was run through NHS procurement.
So the patch enables, the patch, I don't understand, I'm led to believe the patch is mailed to somebody's house, they apply it, and it monitors a person for 14 days. And from that, you're able to get a very rich report about the condition of the person, the cardiovascular condition, sorry, in relation to rhythm management.
Well, absolutely. So there's two aspects to this. First of all, this is a diagnostic test. So if in the old-fashioned world, the patient used to have to come to hospital and have 12 or 3 ECG leads fitted to them, connected to a box that they'd wear with a belt around their waist. And they couldn't shower, they couldn't swim, they couldn't exercise, yet they were supposed to be doing all the things that brought on their symptoms. They would then come back to hospital, we'd take the monitor off, and then we'd analyse it. And because we had a finite number of monitors, patients would often wait 4 or 5 weeks before they'd be called in to have the monitor put on. We'd then take the monitor off them. Our ECG technicians would analyse the data and give us the results. So this took 6 weeks on average, whereas the idea of a patch that you mail out to the patient, they put it on, they wear it, and then it's mailed back and interpreted for you, resulted in a significant reduction in our time from request of investigation to result availability. And that difference was 6 weeks with the old-fashioned technique to 20 days with the new patch. So 1, we got the results much quicker. 2, the patients didn't have to attend hospital twice to have the ECG monitor put on and taken off. And 3, we increased our diagnostic yield threefold. So by wearing something for 14 days, you massively increase the number of positive findings that you're able then to relay to patients. So we saw an increase in our pacemaker implant rate, our ablation listing for getting rid of supraventricular arrhythmias. And perhaps most importantly, if a 14-day monitor was negative, we had the confidence to write to the patient and say, we found nothing. You had symptoms during this that corresponded to non-significant, non-pathological ECG changes. Be reassured. So we then also reduced our outpatient follow-up significantly. So this was a win-win situation all round.
If a patient has some sort of dangerous arrhythmia during the 14-day episode, can you contact them or can they contact you?
They can contact us, and there's contact numbers being provided to them. So yes, that can happen. And one of the fears was that if you wear something for 14 days and have a syncopal episode or you lose consciousness, we still told patients to come back to us earlier and we could take the device off and monitor them. But we had exactly the same problem with the old-fashioned system in that they'd be waiting for weeks to get it put on. They'd only be wearing it for 1 day, so it didn't pick up many events. So we found that this was not only a safe way of monitoring patients, it improved our diagnostic yield and massively increased our confidence to discharge patients with non-significant symptoms and diagnoses.
All right, thank you. I just one more question regarding the data. I think is probably the most important thing because it seems to me the patch is interesting, but the data is everything. So what will you do with all of this wonderful data that you're collecting from the devices and from the patient population that you have in the northwest of England?
So the first thing that we've done is, because we did this both within our hospital practice and our very large community service, we put a couple of abstracts together. We presented at the European Society of Cardiology, both our clinical outcomes and our cost efficacy, because one of the most important things that this evaluation showed us is that it massively increased the availability of our ECG technicians or our physiologists who previously used to have to fit the ECG monitors, take them off the patients, then interpret them themselves and produce a report. Now, the patch is mailed out, mailed back. We get a report that comes straight to the consultant. So we liberated really important physiologist time, and we have a national, and in fact, there is an international shortage of physiologists. So this was one of the really important bonuses of this evaluation, if you like, that we were able to put more of our physiology staff into the catheter lab to support intervention and pacemaker implants, rather than doing what they considered mundane interpretation tasks and fitting monitors on sweaty bodies.
All right. Well, thank you, Professor Wright. Is there anything else that you'd like to mention that the facility is doing right now in terms of interventional or anything revolutionary that you're examining?
Well, we're doing a number of key, not necessarily first in man, but we're heavily involved in what we call modular technology. So the implementation of leadless pacemakers and subcutaneous ICDs. We're looking at the latest technology for ablating atrial fibrillation. And of course, one of the important things when you're doing AF ablations is that you never quite know how successful they've been, because patients can have silent atrial fibrillation, which still puts them at risk of stroke, but they don't know they're having it. So the only way to be absolutely certain that they're not having it is to implant a device, like a linked device or a pacemaker, if they happen to have one. And that's really not practical and it's very expensive. So we suspect we're going to be using our wearable patches, our Zio XTs, to evaluate the success of some of the newer AF ablation technologies. And I'm hoping that we'll be able to get wearable patches out to 30 days or even more to give us more confidence that our AF ablations have been successful.
Absolutely, that's wonderful. Well, I thank you very much for your time today. You've been very kind with it, and it's been a pleasure. And I look forward to talking to you again in 6 or 12 months about the success of Zio and the other activities that are going on in Liverpool Heart and Chest. It's been a real pleasure, and thank you.
Thank you very much indeed.